Welcome back. Dvora and I have so much to share. This is going to be a really interesting little debrief episode as a follow up to our incredible episode that we co led. How do we
Yes,
phrase that?
I would
Co-led,
call it
love
that.
it.
Right.
Co-led with Dr. Heather Nixon. And I learned so much in that episode, Deborah, but you and I left being like, oh my gosh, we have so much to talk about still. This was such a conversation starter for us as therapists. And we got into a bit of, the emotional impact, the trauma that we see in these experiences, in C-sections specifically, and when there's pain felt and patients are not believed or they're not heard or they're not listened to. And we really just scratched the surface. So you and I are
I
going to
agree.
unpack so
Yeah.
much more of this in this kind of debrief follow-up episode to our episode with Dr. Heather Dixon.
I think the thing that one of the biggest moments for me was where I realized that what's her guiding principle for change wasn't necessarily like, well, women shouldn't feel pain, although that was really important. To me, what I heard her saying was we we can impact better outcomes in the long-term health and wellness of our patients. And that was like a
Yes.
flip the coin on the head conversation. It wasn't just it wasn't focusing in only on we need to have pain-free births or pain-free experiences. It actually was a full-on recognition of the idea that good medical care at bedside and beyond could deeply impact the post-birth experience for women, which you and I know, but clearly was a new experience for many physicians. Because in many ways, I think that she expressed it like, we're done our job. Mom is alive, baby's healthy, the outcome measures were positive, but there was so little consideration to the implication of a much more complex kind of expression of that birth process. That was one thing. And then also just that she was giving us some newer data about when there is a quote unquote negative outcome in the birth experience, that there's actually potentially physical ramifications to those experiences in the long term for these women, both biologically, while we know, as well as emotionally. So that was where, I mean, what did you think about that when you heard her describing that?
Yeah. Oh my gosh. She shared so many nuggets that I have so many thoughts on. But I thought that was profound. I thought that it really widened the scope of what the goal of the impact is here, and is much more in our wheelhouse than
Yes.
I maybe originally thought that we had. I thought we were kind of bridging the gap. We had gotten like halfway there, but her goal and her goal for the outcome was much less about we need to make sure that C-sections are less painful when patients claim that they are experiencing pain, and more so about like the way that we communicate with our patients matters and it
Yes.
impacts outcomes. I'm like, yeah, I know, right? It's crazy. But also,
Right.
like, in that vein, I think something that I wanted to mention and didn't get a chance to in that was that anesthesiologists, as she mentioned, are intraoperative. So that, yes, they get their outcome, but they also have absolutely zero follow-up with patients. So
Right.
how are they supposed to know what happens? At least OBs get like the 6 week. I mean, there should be way more than that, but that's a separate
Sure.
conversation.
Mhm.
Like, at least they see patients 6 weeks after, and will sometimes good OBs will recognize, oh boy, you've got some trauma going on here. Like we've
Right.
we've we've got to notice this. And I'm putting the pieces together as to what happened in your birth experience and why that was experienced as traumatic to you.
Mhm.
Anesthesiologists never get that opportunity. They never see that. So part of
Right.
me kind of understands why this would be like so not in their
N
wheelhouse.
and I think also, it was interesting. She was talking about, like, having a conversation with the anesthesiologist, and I'm going back to my own birth experiences, and, I've had, thank God, more than one, but I don't remember meeting an anesthesiologist for more than 5 seconds before procedure. There was like, "Hi, how are you? I'm doctor," maybe not even so and so. "I'm here to perform the procedure." and let's get you set up. And
Yep.
there was never, ever a pause where anybody's anything I need you to know, anything I need to know about you, anything that, what are your goals? I mean, that was never part of the conversation. And I remember after that first experience with anesthesia, which actually repeated itself every time I had a baby, was where I began to say, all right, before you start, my right side does not numb the way my left side does. But that's me. And so I was able to say, everybody, hold on 1 minute before we continue. So you know this about me. That's, I think, one of the only like flaws in the communication stuff here is that I don't think that most women are going to meet their anesthesiologist in a way that feels like, hi, I'm here to have a conversation with you. Is that your experience as well?
Yeah, I think that's my experience from clients, and I think they're trying to do a better job of this. I was actually talking to an OB anesthesiologist the other day that I'm friendly with, and something came up that I think is maybe a frustration point for some anesthesiologists, which is that when someone is attempting a vaginal delivery and they have decided they do not want an epidural, no matter what, like that, they feel very strongly as they get to, right? They do not want an epidural. They don't want anesthesia anywhere near them. They don't want to have a conversation with anesthesia. They don't want
Uh,
that to be a part of their plan. And so then, if that patient is a patient that ends up having to have a C section, which we hope is not the case, but if that happens, then they've had zero contact with the anesthesia team.
right.
And so there's all these kind of layers at play here, but also the system, right?
Yeah.
That God,
But I like how you just differentiated that if somebody's coming in with this mindset of no anesthesia, that often, I think, often, at least my experience is that often that C-section can be in the space of, okay, now we're going to we think it's time for you to have a C-section. Often it's, we need to have a C-section right this second.
yep,
So there's never been introduction to the concept of the need for pain management or pain control, or in the event that you need this, I'd like to introduce you to the person who would potentially be that person. Like that is within the system, doesn't exist because we really have that mindset of like, we're not going to have any bad outcomes. We're just going to have the planned preferences. I love how she picked that up, that birth preferences versus birth planning, right? But we don't, I think that really kind of cuts short, or really it short shifts the, if that's even the right word, the patient experience, right? It's not allowing the patient to understand, well, there are other outcomes that could happen. And the more you know, the more empowered you would be to make choices in that moment, especially when there isn't time to make choice, there to make a choice. It's about getting the baby out safely.
yeah. I couldn't agree more. I think, and part of me gets to a point where I'm like, yes, we can't plan for everything.
Right.
And there is so much that can be done to mitigate trauma. And part of that is having preferences when things, we were just talking the other day on my podcast about catastrophic birth planning and how important
Yeah.
that is. And this is a part of it. Okay, if I do end up with a C-section, what is the plan for pain management?
Yeah.
What does that look like? What are my exactly like Dr. Nixon was talking about with when we get to a point where if you can still feel it, if the block isn't working fully, what do you want the first option to be?
Mhm.
Here's what I have for you. We can try some IV pain meds. We can try some ketamine. We can try whatever it is. Or that person decides, that patient decides, I want to, if I feel pain and I say done, I want you to put me under. Like
Right.
that's it.
You know what I think about also, like, as you're saying this, there's a certain, I have to, I express it as like, there's a certain kind of like, we'll take care of you perspective from very often from medical care, where it's like, you don't have to worry your pretty little head about that. And there needs to be, I'm not going to say the patriarchy, but we could put it in there if we really want to, but just that, that that is the perspective that I think has kind of translated down into medical practice of like, you don't really need to know what drugs I'm giving you as long as you know that I'm going to give you the drugs. And what she was saying to us, Dr. Nixon was expressing, no, be empowered with the knowledge to say, what are the drugs you're going to give me? What would the plan be? And as we're saying this out loud, as I'm thinking about it, what if we as therapists would encourage our clients that, but hey, when you go in for this unmedicated planned birth that hopefully goes exactly according to plan, Once you're getting settled in the hospital, why don't you ask the nurses if you can meet the anesthesiologist that's on call today? So you can say, "Hey, this is my plan, hoping it goes according to plan, but talk me through a little bit about what my options would be in the event that it doesn't, or if things go in a way that is more unsafe for me or unsafe for the baby and we have to transfer over to a surgical experience." Like, as I'm thinking about it, I know most of us don't want to think about those quote unquote worst outcomes, but boy, does it feel different when the worst outcome is planned for. Yeah.
Totally. Yeah, it
Yeah.
feels like you have a say in it and a choice in a matter when you wouldn't
Yeah.
otherwise. I think also something else I do recommend to people who are actually having any kind of surgery, but if you know in advance that you are maybe going to have a planned C-section, or maybe you're someone who is attempting a vaginal delivery that has some risk of it turning into a C, like a VBAC, etc. Um, Calling ahead, you can speak to anesthesia on the phone. You
Mm,
can schedule an appointment to meet with anesthesia at your hospital.
really.
Um, yeah, and so
I never even realized that, you know?
yeah, at the very least, you should be able to get a phone call.
Mhm.
I have done that before for surgeries myself. I highly recommend it to patients who are nervous, and getting just like a little bit better understanding of what the options are and getting their concerns heard. And then being able to take the language from that conversation and apply it, because it might not be the same anesthesiologist, of course,
True.
that's on call, but being able to use again the language that was used in that conversation with that anesthesiology department member and apply it to when you go in for your delivery can be really helpful, and again prepare you in ways that
Yeah.
you wouldn't maybe have been.
And I think also, helping our clients understand that they can ask more questions. If you don't understand, well, why would I get ketamine? I thought that's a drug, right? Or I thought that's something that, you can get a ketamine treatment. I don't understand why that would apply to me in an inpatient setting, in an anesthesia experience. So when you ask the questions, you are more likely to feel more confident, I hope, in I have knowledge moving in here versus just the assumption that they will take care of me. That changes the way that you experience that birth for sure.
Yeah.
Yeah.
And going back to your piece about paternalistic care, which our medical system is a paternalistic care model, it unfortunately just is what it is.
Mhm.
And so when we're working within that model, something that stuck out to me so much about our conversation was the way that she talked about dosing anxiety meds for a
Yes.
patient who needed it. Because one of the biggest fears that I have from really anxious patients is that, well, yeah, I don't want to feel anxious, but I also don't want to be so loopy, which does happen to patients when they trigger the like, I'm so anxious, I'm going to freak out. Then they get so, for lack of a better term, doped up that they don't remember anything, or that they're
Yes.
not fully present. And they're like, that's I would have rather have been anxious.
Yes. Yes,
Eh,
notice that, and how she described that conversation was, is this time to proceed? Would this be a good time to move this plan forward? Now would be a time for us to make a decision. It wasn't like, "Oh, it's time to give you meds," which
Mm-mm.
I think for many people, like, if you're in a trusted space with your provider, you may be just saying, "You do what you feel is necessary at that time." But I think that for those of us working on the other end of it in the aftermath, a better outcome is I made a choice. I had a discussion. I had we discussed the plan and we followed through on that plan and I felt cared for. And I think
Yeah.
that the way she described it was like from our textbooks rather than from hers. And I thought that was just incredibly admirable to hear it. Yeah,
Yeah, it's collaborative. We want to
completely.
feel collaborated with, not like things are happening to us. And
Mhm.
even the medicine piece of that with, she didn't just say, "Okay, now's the time and now you get a full dose of medicine," and like, I don't know, it could make you loopy and out of it. It could not. It was incremental. It was,
Mhm.
let me give you a little bit, 2 to 3 minutes later, check in, oh, a little bit more, 2 to 3 minutes later, until they got to a place. Yes, it takes more time, it takes more effort, but that patient then got to feel okay enough to be present
Yeah.
for her baby's birth
Yeah.
experience, which makes just all of the difference.
It really does. It really does. I think the way that she speaks to her patients is quite unique. There was another, I think also the piece of, I think we will often hear when a patient says, I have a lot of worry or anxiety. Oh, don't worry, you'll be fine. I got you. We're good. We got it covered. That isn't actually what I need to hear from you as a patient. And when a physician or a medical provider turns back to you and says, "Tell me what you're worried about. Let's talk this through. Let's make a plan." I acknowledge that anxiety is real and worrisome and could cause significant distress. Well, guess what? You've just addressed my anxiety directly. And you're going, it's going to probably even going to mitigate my anxiety because I know
Yes.
that you're on my team. So I think sometimes, again, from the training many people have is reassurance. But what we're expressing to you is reassurance is not exactly what a patient needs. Yeah.
It's not. It often makes it worse. And I always try to
So,
educate patients to say in that moment, I hear that you're trying to reassure me, and I really appreciate that. That's actually not helping my
yeah,
anxiety right now. What I need is for you to tell me exactly what you would do in XYZ scenario, how you are prepared. We get this a lot with like someone seeing my story and telling their provider, "Oh, I'm terrified I'm going to have an amniotic fluid embolism." And their
right,
provider's like, "That's never going to happen."
right,
It's like, that's actually not helpful.
right,
What would
exactly.
you do if that happened? Because 100 have to happen a year, unfortunately. So,
Right,
like,
right.
what if it lands in your lap? What's your
Yeah.
how are you prepared? Same with anything else, right? Like hemorrhage and things like that. In this case, with a C-section, what are you going to do if the block doesn't work fully?
Mhm, mhm. Can we talk a little bit about the partner? I felt
Yeah.
one of the most powerful outcomes that she speaks about is this idea of saying, "Everybody stop right now." That idea of saying, like, the legal perspective was, "I do not consent," but the emotional perspective is everyone hands off the table, basically, hands off the patient, stop, pause. There's something here that needs to be fixed, addressed, paid attention to. And I want to talk a little bit more about that. Like, what are some of the things that you see is most helpful in working with the partners of people who are going through anything that, what are we doing to address the partners that they can be that advocate for our patients?
Yeah, this is such a good question. I have like mixed feelings
Hmm.
on this topic. Um, and the reason I have mixed feelings is because 9 times out of 10, the partner fawns even more than the patient.
Okay, explain the word fawn
Yep,
to the audience because I think not everybody understands that.
for sure. So fawning can be and I'm using it less in the trauma way here. So let me just explain really quickly. Fawning can be a traumatic reaction or a trauma response to a situation where you can't run away from it. You can't get away, right? So often in a hospital. And, like, freeze is one, right? Fight, flight. Can't fight, can't run away. Often we fall to fawn, especially in paternalistic medical settings.
Yeah.
We have been taught to revere medical providers. And because of that, we have also been taught to, in a sense, be submissive, be passive, accept the care that is provided to us because they know better.
Hmm.
And anecdotally, I would say, I see partners, and I will say mostly male partners, really struggle with this. And by that, I mean there's even more reverence to medical teams. This is completely anecdotal. I want to be very
So
clear about this.
interesting. Tell me more.
There's no research on this at all right now. Um, I would say that I see partners have a very hard time standing up to medical teams.
Wait, do you think that
Mhm.
that's specific in the birth environment?
Yes. Yes,
Okay,
I
so
do.
to clarify, in the
Thank you.
birthing
Yes.
environment, that makes total sense to me.
That's all I
Like,
ever talk
I'm
about,
out of my
sorry.
yeah, exactly.
I
Like,
forget
I'm
that,
out
like,
of
there's
my
a whole
league. There's other
yes.
there's other surgeries we could be having, but, like, yes,
Yes, my
right?
bad.
So, I'm out of my league. You guys are in charge. You know what's best. It's your body. It's a woman's thing, and it's not even this is not an articulated experience or even well-developed idea. It's just, like, a natural instinct to just be like, "Hands off. I don't know this world." Right?
Yes,
Okay,
that.
that makes total sense.
It's the naivety, the lack of,
Yeah,
education. So this is not every partner. They're
right.
wonderful partners. So that's why with this conversation, I agree, we should get partners educated and advocating. And I think when in this particular situation, not only with birth, but in an OR setting
Mhm.
where it's very sterile, don't touch anything, You're not allowed to come in until after the epidural is placed. You have to be in this whole suit. Like, they're just so far out of their element if they're not
Mhm.
familiar and comfortable with a medical setting. Their
Right?
partner is open on the table,
Right.
and we want them to say, "Everyone stop."
I hear it. Mhm.
It's
Mhm.
hard. I'm not saying it can't happen. I'm just saying it's really, really hard.
And what you're also saying is that if we put any kind of onus of responsibility and they fail at that responsibility, then we're now causing potentially really impacting a negative, a really painful outcome for the partner as well. Like, I failed my spouse, I failed my partner, I failed my wife, and therefore I can see the and therefore unfold for a long period of time afterward. The
Yeah.
one thing I just wanna clarify also, when we talk about a paternalistic experience, that doesn't mean that the physicians are male,
Nope.
right? It's
Nope.
that the paternalistic it's from an education model, it's a way of training, it's a way of "Don't question us." That perspective can be a male or female identified physician or medical provider, prescriber, etcetera. So, I think that's important to
Thank you for
recognize that
clarifying that.
we
Yeah.
don't necessarily know if we have a better outcome with female doctors or male doctors.
Oh,
I
yes,
don't
we
I
do. Oh, yes, we
Okay,
do.
tell me.
We do know. There's research on having better I don't wanna misquote it. I think it's surgery. I think it's surgical. But female patients have better outcomes. Actually, I think all patients, but I'll have to look it up. I'm gonna look it up. There
Okay.
is research that shows that female surgeons have better outcomes
Wow,
medically.
wow.
Um, I'll find it and I'll put it in the show notes so that you know that I'm not
Yes, we're gonna have
talking
to
out of my butt here. But to your point, yes, the paternalistic care model is the care
Exactly.
model, the
Yeah,
education, not
yeah.
who is providing it. But so I kind of want to circle back around because I got us a little bit off track. But I do think that just as we want patients to advocate for themselves, we also want partners to advocate. And I'm by no means saying that they're not responsible, that they don't know enough so we can, remove all responsibility from them. Absolutely not. Um, but I'm just having us kind of look at the scenario of what we're putting both patient and
Mhm,
partner up against, which is why I love the Retrievals podcast because it has those nurses in
yeah,
there advocating so hard for patients and their pain during C-sections. And I do
yes.
think I always come back to nurses,
Yeah, yeah.
and not to put all the onus on them, but they are truly the champions of their patients, and they make these changes by standing up to anesthesiologists, obstetricians, whoever's in that room performing those C-sections.
With the recognition that there's risk associated with standing up against that
Yeah,
level of medical
huge,
team, right?
huge
That
risk.
with that, kind of left top down approach, there really is a risk for them to be like, I am not comfortable with this, or this, everybody needs to stop, or something needs to change, or we need to address this, right? Because while we might say, yes, speak up, the system doesn't necessarily support the idea of speaking up loudly enough to be heard. Yeah.
Yeah. And we saw that
Yeah.
in Claire's story, right?
Totally,
No
totally.
one spoke up.
No one said anything. Yeah. I'm wondering about, I'd like us to shift into in the outcomes, meaning we get the aftermath. And the aftermath is I was in so much pain. Nobody said anything. And as much as there's going to be movement, and Dr. Dixon is at the forefront of movement and change, it takes a very long time to change a system, and it takes and it might be 100 years before things will change in the way that we will no longer have, these kind of experiences in our offices. If I'm still doing this in 100 years, we need to have a conversation about that too. But that
Yes.
being said, are we what are we thinking about when that patient walks in our door about what is the outcome when there is either a pain scenario at C-section or a nobody heard me? What are the things that we want people to understand the most about what that looks like in our offices as therapists?
Yeah, I want people to understand that it's not just a scary thought. It's not just a memory that was hard. Um, this creates a long term impact on patients' belief of themselves and how they are cared about as a human.
Mm,
Because so much of trauma, especially in these scenarios, comes down to like dignity, right? Being heard and listened to, but also being cared for as like a human being, not just a body. And so the impact of this, again, isn't just like I was in pain and it was scary. It's no one cares about me. I'm alone in this. I can't be heard. And these themes of I can't be heard are not just like in medical settings. These are impacting patients now in their everyday life. They're getting activated when they get talked over in a meeting at
mm,
work, well far beyond a typical like frustration or annoyance because of this experience.
mm. Right,
That's just
right.
one little tiny example of like an everyday thing. But now they're activated and they can't even like hang in there for the rest of their workday.
Like, it becomes a belief that they deeply internalize, and
Yes.
especially internalize over time. And even if, as an outsider, you might look at it and say, "But that's not what happened. I mean, that's nobody intended for that, or that wasn't the intent. That wasn't. I mean, that wasn't really what happened. You just had pain." But what we're telling you is that the experience goes so much wider and so much deeper. And when it really begins to be acknowledged, and we begin to say, actually, it's more than just this was a bad experience, or as we say, a bad outcome, right? Then we begin to understand the long-term implications of these kind of traumas.
Yes.
Yeah.
Absolutely. And also on the other side of that, man, I could talk about this for days. But on the other side of that is the patient who, as a child, was told over and over again that their feelings don't matter, that
Hmm.
they're not important, that they need to just suck it up and stop crying, et cetera, et cetera. We see that a lot. Is now the patient that's lying on the operating room table being told, just push through, just a few more minutes as they're screaming their head off because they're in so much pain.
Right.
That is just
Right.
another moment of their brain, their nervous system saying, see, told you you don't matter.
Yeah. Yeah. Can we also speak, just because we can't ignore the other people in the room? When there is an experience like that in an operating space or in a labor and delivery space, we have nurses and physicians who are also impacted by that experience. And especially even if they're trained that way, like it's just pressure or whatever the wording is that they give themselves to just authorize continuing, there is an impact on their experience that is harmful to them. And maybe we can, I know that you are seeing nurses in your practice, especially, and physicians in your practice. What do we want to acknowledge that even as a bystander, right, that the trauma of watching this unfold in front of you, even when the outcome is positive, that the trauma is lasting on your body and on your heart and mind as well?
Yeah, this is such a good point. And this even goes for people who don't realize they're impacted. So we have the
Hmm.
nurses and the providers who are torn up about these experiences, right? Who are visibly upset. We heard it in the Retrievals podcast. The people who were in that room for Claire's delivery, it was traumatizing for
Yeah.
them. And
Yeah.
then there are people who just kind of go about their life and this is kind of normal. Sometimes people feel pain. They get them through it, healthy outcome. But we know that providing trauma informed care feels more aligned to our nervous systems. We know that it actually doesn't just benefit the patients, but it actually benefits the providers delivering it
Mm.
as well. And I think we don't recognize that benefit enough. We always talk about patients, right? And receiving that care and how much it changes their outcome. But that alignment with like doing something that we know feels good for a patient that puts them in a better situation for a better emotional outcome is also net positive for the providers providing the trauma informed care.
It's amazing when you say that, because if you think about it, what could be a better selling point for changing the way we teach our medical teams, right? That
Yeah,
this is actually good for you. It's not just good for the patient, which is an altruistic approach, but a
totally.
more egocentric approach is actually this makes you a better doctor, makes you better able to manage your life, your responsibilities, and feels differently for you as a medical provider across the board. What a selling point that really could be. Yeah.
Yeah. Yeah, I know.
There's so much here. There's
There's
so much here.
there's so much. And
Yeah.
I hope, yeah, I hope, both providers, nurses, and patients listening see the needle moving,
Yeah.
see the progress that we are inching towards here, because
Yeah.
having OB anesthesiologists, having providers say, "Oh, so this is really not okay. Like, we need to
Yeah.
change this." And something that I found so cool about that conversation was when she mentioned the approach being, oh, I forget the word she used, Devora, something about focusing on not just the humanistic piece of it, but also like the data per se.
Mhm. Mhm.
So when she talked about how, what is the pain scale? You didn't chart the pain scale. I hope I see that pain scale charted later tonight.
Compliance. You
Thank
talked about
you. Thank
compliance
you.
change. That was so powerful, right?
Yes,
Compliance changes outcomes and changes everything for the future. That was so, so impactful. Yeah.
because that's not my wheelhouse. So
Right.
I'm like, feelings, like make your patients feel more comfortable, like see them,
Exactly.
hear them, like
Right.
do the things. And I feel like that is, I kind of compare it, and we need both of them. It's like art and science.
Mhm. Mhm.
There's like an art of how we provide trauma informed care. And there's also the science of it.
Yes.
And the data here, the compliance is going to push in a way that I did not recognize until we just had this
I
conversation.
agree.
How we can
I
like
agree.
sneakily do the
Yes.
compliance piece that
Yeah.
actually creates and continues the humanistic approach.
I agree. I agree. And I think that's also one of the values of like, I can get up in front of a room and talk to a bunch of doctors, but it will not be as impactful as a doctor getting up in front of a room and talking to a bunch of doctors.
This.
And so
Yes.
that the fact that she's leading the charge, she is, we didn't even get to introduce her fully, but she's like a Northwestern University professor and physician and practitioner and teacher. She's extraordinary. And she's leading the charge on not only a local, but also a national level. Her work goes far beyond a podcast.
Oh,
But
yes.
that's where change is going to happen on an international level. And having her do it is just different than us as therapists. That's for sure. So we'll have
Absolutely
our
is.
lines and our realm, and she'll have hers. But I think people should feel really hopeful that things are changing. Yeah,
I do.
yeah,
That podcast made me feel so hopeful. I
I
hope it
agree.
helps others.
I agree.
Yeah.
I agree.
Just
This was
watching.
fun. This
It
was fun.
was.
Kaylee, thank you
Yay.
so much once
Of
again.
course. Thank you.
And folks, you'll be able to find both of our podcasts on the Birth Trauma Mama. Mine is called Misconceptions. Hopefully, you'll get to know both of us a little bit better. We will be sharing this conversation on both of our platforms and spreading the good word. So thanks, Kaylee.
Yes. Thank you so much, Dora.